It's a very important topic and it's a day-to-day topic. And we find it's not that simple, this topic is. So Hyperemesis gravidarum basically, as you know, is a very, very, very important. Maybe it's a revision for all of us about this topic. And day to day, we face the patients of nausea, vomiting during the pregnancy, and it's very common with it. So the important point, the nausea and vomiting of the pregnancy is worldwide and all throughout the pregnancy we find all these problems, and it's not localized to our country or this country or that country. It's how we say that the nausea vomiting is being diagnosed. It's onset in first trimester and we should otherwise causes excluded. It affects the 80% of the pregnant women. How is the hyperemesis gravidarum diagnosed? And the important thing is this is a protracted NVP with less than 5% of weight loss. When we say this patient is having hyperemesis gravidarum, just keep two things in mind. There should be a protracted NVP with more than 5% weight loss, electrolyte imbalance, and dehydration. So the three things are important when we say the patient is having this thing, and it affects 2 to 3% of the pregnant women. So simple nausea, vomiting, onset in the first trimester, it includes the 80% of the pregnant women. While the hyperemesis gravidarum, more than 5% weight loss, electrolyte imbalance, and affect 2 to 3% of the pregnant women. I'm sorry, quite sorry. So these are the risk factors basically to whom that the hyperemesis gravidarum will be there. For example, if she is having the previous pregnancies with hyperemesis gravidarum, nulliparity, multiple gestation, trophoblastic disease, greater body weight. So it was a really important in the risk factors. Those who are having greater body weight, having the chances of more nausea and vomiting, more common in industrialized urban areas than the rural areas, and risk is reduced with the advanced maternal age. So older the female, less are the chances of this thing. But the simple, now we'll just see the day to day. I am finding many of my own people are in the this group, like from Dr. Obeja, Madam Jyoti Haq, Rajput, and many more my friends are there. Ritu Khanna is also there. So many people. So this is a simple case scenario. 26-year-old primary gravida, 7-week gestation, excessive salivation, and heightened sense of smell, vomiting since 1 week, not able to tolerate food. So the nausea vomiting of the pregnancy typically onset between the 4th and the 7th week, peaks at the 9th week, and if starts after the 10th week, other causes should be ruled out. So simple nausea vomiting, 4th to 7th week, just make it a point, peak at 9th, and after 11-12 weeks, she's okay. But if it starts after the 10 weeks, other causes should be ruled out, and it affects the 80%. So simple nausea and pregnancy, 80% of them. So how to manage? A primary care outpatient basis, no signs of dehydration. We just need a reassurance. We need a support. We need a oral hydration and a simple dietary advices. And sometimes we should give the antiemetics, simple the doxylamine succinate and a pyridoxine, the simple thing. Now case scenario, the same female 2 weeks later presents with persistent vomiting, appears dull, lethargic, BP on the lower side, and loss of weight 3 kgs. So it's a dangerous patient again. So at the 2 weeks later, so it's a hyperemesis gravidarum diagnosed when protracted nausea and vomiting with a triad of this is more than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. So simple case up to the 9 weeks is perfect, but it's up to the 2 weeks more and having these 3 things. So this is a very important weight loss, dehydration, and electrolyte imbalance. And severe form of NVP affects 0.3 to 3.6% patients of the pregnancy. Now the other signs and symptoms will be gastrointestinal nausea and vomiting, tylism, excessive salivation, fatigue, weakness and dizziness, sleep disturbances, hyperreflection, dysgeusia, and mood changes, anxiety and irritability. So now what do we have to look for? Number 1, hyponatremia, hypokalemia, low serum urea, raised hematocrit, ketonuria, and severe cases, we need to see the metabolic acidemia. So hyponatremia, hypokalemia, serum urea, and raised hematocrit, ketonuria are important. And abnormal thyroid function. It is one of the reasons for the hyperemesis gravidarum also. There can be abnormal thyroid function. Sometimes the abnormal LFT, that's a transaminase, is also abnormal. So ambulatory daycare management, this is a simple patient and we are just doing the ambular. When primary care measures fail, PUQ score that is less than 30, that's a then parenteral fluid, parenteral vitamins, antiemetics are given. And inpatient management for these presenting with at least one of these symptoms, continued nausea and vomiting, inability to keep down oral antiemetics, we are supposed to admit the patient. And if she is associated with a ketonuria or a weight loss despite oral antiemetics, we should confirm and suspected comorbidity, for example, UTI, inability to tolerate oral antibiotics, we have to do the intubation. These are the green guidelines 2016. Now, what should be the management goals? To determine the severity, correct the hypovolemia, reduce the symptoms, prevent the complication. So, the classify the severity of the nausea and vomiting. There is a score which is we call it PUQE score. P stands for pregnancy, U for unique, Q for quantification of MSS score. It's very, very important. We have to do any objective or a validated measure for the severity of nausea and vomiting, green from 2016. So how to calculate the PUQE score? Total score is serum replies to each of the 3 questions. So mild is less than 6, moderate is 7 to 12, and severe is 13 to 15. So there are the questionnaires and 3 questions should be asked. The mother is PUQE score, 24 scoring system is there. In last 24 hours, for how long have you felt nauseated? Not at all, 1 hour or less, 2 or 3 hours, 3, 4 to 6 hours, 4, and more than 6 hours, that's a 5. Second question is, in last 24 hours, have you vomited or thrown up 7 or more times? 5, 5 or 6 times 4, 3 or 4 times 3, 1 to 2 times 2, and I did not thrown up, that's a 1. And the last question is another important. In last 24 hours, how many times have you had a retching or dry heaves without bringing anything up? So the no time 1, 1 to 2 times 2, 3 to 4 times 3, 5 to 6 times 4, and 7 or more times the 5. So these are the scoring system. We have to add and find it out how it works. Now evaluation. The test is urine analysis. We'll see the ketones and pus cell, electrolytes. We will see the hyponatremia, hypokalemia, hypochloremic alkalosis. For creatinine, for the pre-renal and the renal failure. So full blood count, infection, blood glucose monitoring, exclude diabetic and ketoacidosis if diabetic. So full blood count, infection, anemia, hematocrit and TSH are very, very important with blood glucose and exclude the diabetes. Sonography, confirm the viability of the fetus, exclude multiple pregnancy, exclude trophoblastic disease, and now what should be the management? Medication that can be used vitamin, pyridoxine, antiemetics, doxalamine, chlorpromazine, metoclopramide, and ondansetron. Acid-reducing agents, omeprazole, antihistaminic sometimes, that is a diphenhydramine, and herbal medication is very, very important. Sometimes we have to give as a tender loving care, we have to teach the patient, that's a ginger. And corticosteroids in a serious cases, very, very. Now the safety and efficacy of the pharmacological drug, the first line of the treatment is simple antihistaminics. They are doxylamine succinate and vitamin C, that's a pyridoxine. Second line, metoclopramide and ondansetron, and the combination of drugs when no response with a single agent. And third line, which is another important thing, is a corticosteroid with the standard therapy has failed. So these are the line of treatments which we should do. Now, how much ondansetron? 4 milligram to 8 milligram BID, QID, IV. Metoclopramide 5 to 10 milligram BID or QID, IV or intramuscular. Then third is a promethazine 12.5 to 25 IV or intramuscular BD to QID. It's a category B. So, and the adjunctive therapy is acid reducing agents. That's omeprazole 20 milligram twice a day. And with all this, we have to do the rehydration therapy. That's a linger lactate solution, normal saline, additional potassium chloride in each bag. So another important point, hypovolemia 2 liters over the 2-3-5 years, 2 ml per kg per hour or 125 ml per hour. Infusion rate adjusts to maintain the output. of the urine, that's more than 1 ml per kg body weight per hour. So the rehydration therapy, for the way we do it in other patients, we are supposed to do in this type of patients also in the same manner. So infusion rate should be adjusted with the urine output. Another rehydration therapy, dextrose infusion to be avoided in the initial replacement fluid, concern of the venous encephalopathy. Continuous hydration maintained with dextrose containing solutions and potassium supplementation 20 MEq kCl. So dextrose should be avoided, continuous hydration and potassium supplementation. If hypokalemia is severe, potassium is added into IV fluids to achieve the concentration of 40 milliequivalent per liter. An infusion rate is 10 milliequivalent of potassium per hour is safe. So we should not go beyond this because the potassium should not be given in a faster manner. Another supplements we can give the thiamine 100 milligram IV with initial replacement, 100 milligram daily for 2 to 3 days, oral thiamine 50 milligram OD and multivitamin infusion daily. Now the same patient, the scenario is changing. Women readmitted after 1 week because we have given all this treatment and now she is readmitted. This happens in our day-to-day practice. And we find it out in our day-to-day practice because in an initial scenario, simple nausea and vomiting. Then after 2 weeks, she has developed a hyperemesis gravidarum, but now she is the same patient. We have given, admitted her and treated her, but now this woman is again, after the 1 week, she has been admitted. Sorry, why it's not moving, I'm worried. She's having the continuous vomiting, then unable to retain medication because oral medication at home we have written, she's not taking, and weight loss is 6 kg. Now we should be worried about it, and altered sensorium. She is not having a good inner senses. We have seen this patients, I think in our practice, if like senior gynecologists, they have seen this type of patients. If the nausea, vomiting and hyperemesis gravidarum not treated well, they have this type of patients. Now, these are the refractory cases. We have to repeat the admissions. LFT increase, seroaminotransfer is seen, 50% increase. Amylase and lipase also change. And ABG exclude the metabolic disturbance of the minor severity. Now, what should be the refractory management of these patients? Hydrocortisone, 100 milligram IV, BD. Then switch to oral steroids and taper tap hydrocortisone 50 milligram BD and injection thiamine or oral thiamine for next 2 weeks. And what monitoring is should needed? Urea and serum electrolytes daily, input output chart, avoid iron preparations. That's very, very important that we have to look for, and thromboprophylaxis with a low molecular weight heparin unless contraindicated. So another important reason for starting the thromboprophylaxis in these type of patients. If persist dehydration, electrolyte loss, weight loss despite all measures, nutrition supplementation by either parenteral or enteral route is indicated. Standard method is via total parenteral nutrition is needed because she has to have the nutrition, but there are the risk of sepsis, bacteremia and thrombosis, and sometimes the nasogastric tube placement with enteral feeding is also needed. I'm talking about some extreme cases. So hyperemesis is a diagnosis of exclusion. Look for other causes. Why she is having this much? It should not be only the pregnancy. She may be having peptic ulcers. She can have the polycystitis. She can have the gastroenteritis. She can have the hepatitis, pancreatitis, genitourinary conditions, neurological conditions. And another important in a day-to-day, sometimes we don't know. She must be having some tumor in the brain and we are treating a simple hyperemesis gravidarum. So neurological conditions, sometimes drug-induced. If she is on some drugs, it can also cause. So the complementary therapies are the home remedies. This is a ginger lollipops, ginger tea. Sometimes the stimulations, acupressure and acupuncture, sometimes it works. I'm not sure about it, but these are the therapies being suggested. Now, effects of the ginger for the nausea and vomiting in early pregnancy there is a meta-analysis and a big study by Thompson M1, Corbin R and Leung Lel. The conclusions say, despite the widespread use of ginger in the diet, its clinical value and safety profile in treating nausea vomiting is still unknown. Our meta-analysis suggests ginger is an effective non-pharmacological treatment for nausea, vomiting in the pregnancy. The efficacy of occupation for the symptom of the management. Again, there is a study. The conclusion says the occupation may be useful strategy for the management of multiple symptoms in a variety of the patients of population, but rigorous trials are needed. Inclusion of occupation is the intervention may improve the patient's outcome. Dietary changes. Number one is gut rest. Avoid triggered diet. Eat before or as soon as hungry. Sorry. Eat slowly, small quantity every 2 to 3 hours. Frequent small meals. Avoid coffee, spicy, odorous, high fat, high sugar food. Substitute with the protein dominant, salty, bland, dry, low fat food. Sometimes eliminates the pills with iron. That's another important thing. Increase the intake of carbonated beverages. Suggested food for the herbal teas, peppermint, ginger, unbuttered toast, frozen desserts are needed. High protein snacks are useful. And a preconception use of a parenteral vitamins may decrease the nausea and vomiting. So if she has planned the pregnancy before, or in a first pregnancy she is having the hyperemesis, in the next pregnancy at least, she should take the prenatal vitamins and that decrease the nausea and vomiting. Fluids consumed in a small quantities, 30 minutes before and after the solid food to minimize the effect of full stomach. Salivation, frequently washing mouth, brushing, mint flavored toothpaste is another needed. Now we come to the complications. What are the complications of hyperemesis? That is, number one is Wernicke's encephalopathy. There is a triad of acute mental confusion, ataxia, and ophthalmoplegia. I think in my practice of 32, 33 years, I have at least seen 2 or 3 patients of this type of things, of Wernicke encephalopathy, and very, very confusing mental confusion. We have to terminate that pregnancy. I am really telling you, those days, mental confusion, ataxia, and ophthalmoplegia. Another complication is due to too much vomiting. There can be a esophageal laceration with hematemesis. I am sure in our practice we have seen patients with vomiting. They start coming with, madam, ab to khoon aa raha hai, but this is also called Mallory syndrome because there is a hyperemesis. Another renal dysfunction, pre-renal failure are the chances, and central venous thrombosis secondary to dehydration can be there. We call it a psychosocial effect, feeling that caregivers did not realize how ill they were. Really, it's very, very important. सास कहती है, माँ कहती है कि ये तो common है, होता रहता है. But when she turns into the hyperemesis gravidarum, we should be worried about. So the caregivers are very, very important. Fear of subsequent pregnancy. Sometimes in the hyperemesis in a first pregnancy, she doesn't want to become pregnant in another pregnancy. Negative attitude towards pregnancy. The same pregnancy, she feels negative. These are the psychosocial effects now that she doesn't have what sort of pregnancy, what I am doing, why I am having this pregnancy. And the post-traumatic stress. Difficulty in milk secretion, marital issues, because the whole pregnancy she was traumatized and sometimes she doesn't have the secretion. Now, these case risk code describing the following complication. Esophageal rupture, just like this. Then case report describing the following esophageal rupture or perforation. That's a Boyer-Heath syndrome. Sometimes there is a pneumothorax because of vomiting, pneumomediastinum, Hammond's syndrome. Wernicke's encephalopathy leads to blindness and a hepatic disease. Deep vein thrombosis is another into the chart. So the fetal outcome, preterm birth, low birth weight, and manifesting the first time in a second trimester, increased risk of preeclampsia. So don't think the hyperemesis gravidarum is a simple thing. It can lead to the preterm birth. It can give the low birth weight, IUGR. It manifesting the first time, it can lead to preeclampsia. Now, when to transfer these patients to the higher centers? You cannot say like that if there is a presence of hematemesis. Number 2, if there are the neurological complications like altered sanitarium, inner refractive cases required parenteral nutrition, they are to be transferred to the higher cases, and in sometimes there is a renal failure. Now, this is the algorithm, what we have to do. Initial assessment, we have to do the PUQ score, assess the clinical complication, that's a dehydration, and exclude the other causes. That's another important thing. If PUQ is 3 to 12, no ketonuria, simply give the antiemetics, first line, dietary changes. If the score is more than 13, very, very important, but no ketonuria, simple ambulatory daycare, second line of antiemetics, oral parenteral or parenteral hydration. Third, if the score is more than 13 and 11, there is a ketonuria present. We need an inpatient management. We need a second line of antiemetics, and steroids should be added. We need a rehydration, and thromboprophylaxis comes into the picture. Now, what is the role of multidisciplinary team? There is not simple that this is a one thing. One is the holistic approach. Nurses and midwives, everyone should be alert. There should be a dietitian for dietary advices. Then we need a physician or endocrinologist to find out another things. What's the another causes for this? Psychological support and a mental health. It's also we include some tender loving care in these patients are very, very important. Mental health by neurologists is important. Now these are the green top lines, the grid lines I have talked about. It's a June 261. It's updated in 2018. Hyperemesis gravidarum, a review of recent literature, pharmacology, and updated guidelines for the management, nausea and vomiting, the hyperemesis, and ACOG 2025. Thank you so much for the patient listening, and thank you so much what I can share as a hyperemesis gravidarum.
Thank you so much, ma'am, for giving detailed information. We received some good feedback. Dr. Rita Thakur is saying that thank you, ma'am, for such an elaborate information on this very common problem in pregnancy.
Thank you so much.
And Dr. Kusum Singhal, ma'am, is saying that great talk on a day-to-day problem.
Thank you so much.
Even Dr. Kishore wants to ask something.
Yeah, he can ask. I think you allow them, whoever there, and raise their hands, they can ask. I like to interact with them. I just like to interact with them.
So delegates, you can ask the questions, and
we have time.
We are getting lots of information from delegates.
No problem. No problem. Hello. I'm not able to see. Allow.
Dr. Rajuka sir,
allow him to speak. Allow him to speak.
Can I? Dr.
Yes,
Kawita.
Sir. Yes, sir.
Kawita.
Yes,
how
sir.
are you?
How are
you? And
I'm good, sir. I'm good.
After Indore, again seeing you, I'm so happy to see you again.
Correct.
And I just, I was listening to you, and I just wanted to share just one incidence of hyperemesis gravidarum. Balki two incidences. One was a doctor's wife, in which the hyperemesis gravidarum diagnosed in the first trimester continued till she delivered. 9 months. एक तो ये था. Number second था, this girl, she was a girl, my friend's sister. She was when I was also young. Tab ki baat hai. And she was hyperemesis, and she was quite bad. Liver function and ketonuria, everything was there, and nothing was being done. HOD ke under admitted. But finally, he took a discharge, and then he asked me separately, please do something. I asked that girl properly, so I took her history. Actually, she did not want this pregnancy. She was a DNB student, and she was being harassed in Gangaram mein वगैरह थी वो, and she did not want this pregnancy. And that is the only, I advise termination of pregnancy. That's the only time in my whole career I have advised. And the day the patient was terminated, agle din she was an absolute normal person. Everything you can. So psychology is also important.
Sometimes hyperemesis gravidarum, just I have suggested. So because if you do in a right way, if you do the correct scoring, if you do the treatment, if you do the correct history, if you put it in which category she comes, what are the symptoms, and it's evaluated properly. So I think and the multidisciplinary thing we take, and a holistic approach, and all those things, then we are able to sort out this problem. But the only thing, termination of pregnancy, and when we used to be the student, but
these are the only times throughout my life, only once I've done. And
but nowadays we don't find much of this.
No, I don't think we'll do it. But that was some special case. And 5% should not be given. We should teach the residents no 5% dextrose. Give saline or DNS. and gut rest should be avoided. We have to keep frequent feeds.
Actually, the dextrose infusions to be avoided in the initial stages of the replacement weight, because there are chances of vernix encephalopathy as we talk.
Yes, and yes, absolutely.
Thank you so much, sir, for that.
Okay, so nice. Thank you. Thank you.
I think many more senior gynecologists are there and they can talk about it for the hyperemesis, though this topic is not a popular one, but this is an important topic. Varsha wants to talk something. Varsha, Dr. Varsha? She has raised the hand. Dr. Varsha has raised the hand.
Good evening, ma'am. Can you hear me?
Yes.
Good evening to all the doctors who are listening, and very good evening to ma'am. Ma'am, actually, in hyperemesis gravidarum, I also face many problems with the patients. In spite of giving them on-dem, doxylamine, succinate, pyridoxine, still patient keeps on vomiting even after IV fluids and after admitting them. So, in spite of all the measures, still they keep on vomiting. So, what we should do next, like?
I think probably I have gone through all my slides as you have heard about Varsha. The thing is important. We have to correctly evaluate. But what stage she is having? Does she need of first line treatment for simple antihistaminic, or she ended up into the second line treatment, metaclopramide or ondansetron, or she needs a third line treatment like a corticosteroid, and we have to
corticosteroids we can give.
We have to categorize with the PU, QU score. No, you just made a score, and very simple 3 questions are there in a PU, QU score. No, there are simple questions.
Madam, this PU, QU score was very good too. It was very informative. Like.
Thank you so much. Thank you so much. Because it's a day-to-day problem, but we are busy in our practices. Sometimes they need a good counseling. Sometimes they need a tender, loving care is also needed. Some psychologists.
As the sir told before, the patient went on vomiting till 9 months until she delivered. Yes. We also face this problem.
So sometimes we have to admit patient, readmit patient, what not, she changes the doctors, what everything happens, with the hyperemesis gravidarum.
They keep on repeated admissions.
And supportive treatment is needed, vitamins, antiemetics, sometimes anti-reducing agents, acid, antihistaminic. Herbal also works, acupressure also works. It all depends on what it's.
Steroids we can give, na?
Yeah, definitely we have to give steroids with the patient, but she has to be referred to higher center the moment we started thinking that she's a refractory patient. Means if the LFT
dose
is
of
changing,
steroids, can you tell?
Amylase are
dose
changing.
Of steroid?
The steroid is
dose of cortic.
I think I have mentioned the corticosteroids doses over there. The regularly which we give in this thing.
We can give prednisolone.
Prednisolone we can give. Yeah.
We can give prednisolone. I had to give one of my residents.
Okay.
Yeah, oral corticosteroids.
Prednisolone is a good drug. Methylprednisolone also can be given.
If she is able to tolerate, then we can end up into the methylprednisolone, the oral corticosteroids also.
Ma'am, how long we should give prednisolone? Like 10 mg we can start with OD or BD?
BD
we have to start. Till how long we have to give, ma'am?
Admit her, see the condition, see her the proportion of all the ketonuria, hyponatremia, repeatedly the things
generally about a week is required. 1 week it is generally takes place.
She needs to be the
urea. Do we need to taper the dose?
No need to taper the dose in 7 days. No need.
Okay. Thank you so much, ma'am.
Yeah, thank you so much.
Hello. Good evening. I am Dr. Sasmita from Odisha.
Hi, doctor.
A very nice stuff, very useful also. What we teach our students that whenever there is hyperemesis, you have to first exclude the multipetal pregnancy and molar pregnancy.
Yeah, they are the risk factors. No, they are the risk factors. I think in the starting, I told you that if the patient is nulliparous, if she is having previous pregnancies, if she's having multiple gestation, and these should be excluded at 10 weeks. If she develops new problem at the 10 weeks.
So all ultrasound should be done immediately and exclude those things.
All those factors. Yes. And if she's having a greater body weight, there are many factors, no? And as advanced age, the hyperemesis is less.
Yes. So and that's our frequent diet. small diets that will also be help her.
Dietary is always
Kal dekh.
all of us.
Kal dekh ke
Dietary is very important.
It is a very common problem with many patients we face. These are very useful, madam.
Thank you so much. Next lecture we will talk about the emergency obstetric hysterectomies. So all of you can join next Tuesday, 7 p.m. Yeah.
This short talks are usually very beneficial for everybody.
Thank you so much. Thank you so much, Sushmita. Thank you so much.
Yes. Thank you.
There is one more question from Dr. Antim Bala Jain. She wants to know any role of micronized progesterone.
See, we don't include into hyperemesis. The pharmacological agents are not for the progesterone, is not for the treatment of nausea and vomiting. If she's having some other problem or she has to put on the progesterone, then it's needed. But first line treatment, antihistaminic. Second line treatment, metaclopramide. Third line, corticosteroid.
Ma'am, one more question from my end. How much its impact, psychologically impact on the patient who are going through this HEG problem?
I know it's a really horrible. They don't want to continue the pregnancy. Number one, they think the caregivers are not doing right things with us because they are not able to understand or make others to understand. Then in a next pregnancy also, they don't want to become pregnant. Sometimes suicidal tendency, mental sensorium loss, what not happens with the hyperemesis. I think all the senior gynecologists who have seen so many patients will be able to justify what I am talking about.
Yes, yes.
All negative attitude towards pregnancy and post-traumatic stress. किसी को तो breastfeeding भी नहीं होता है, and so many mental issues. Thank you so much.
Thank you. Thank you, bye. Good night.
Ishant, we can stop. Nice
Yes,
to
ma'am.
see. Nice to see you all and interact.
Many feedbacks are there for thanks and it was very nice, informative talk, crisp talk, excellent talk. Lots of feedback from our delegates.
Thank you, sir.
So we are coming back with Dr. Kawita Bapat on next Tuesday with new topics, 7 to 8 p.m. So please all log in with us on Shield Connect. So thank you so much for joining us with today, and thank you Dr. Kawita Bapat ma'am for joining and giving us this information on very common topic which is overlooked these days.
Thank you so much.
Thank you, ma'am.
Thank you so much, Shield, for giving me the chance to speak on the subject. Next is the emergency obstetric hysterectomy on next Tuesday, 7 p.m. Thank you so much.
And the delegates, if you have missed this webinar right now, you can also go through on Shield Connect. We have the recorded session, so you can also go through this webinar again on our platform. Okay, so